So good afternoon, everyone. For those who've just joined, welcome to today's CME. So initially, we just started by a background about what this HIV series is going to have for us. So we from the Comprehensive Care Department have a series for you every Tuesday. And we thought we'd start with GBV-HIV overlap and really just see how these two are related, see how GBV influences HIV, see how HIV influences GBV, and just look at the overlap and see what we can do. GBV services in KNH run for 24 hours. We are working towards getting a GBV room that will be called to my center in the A&E. And we give post-GBV care. We give the GBV survivors are actually sent to mental health for further support and counseling, and we also offer STI prophylaxis. So any questions or concerns can be raised in the Q&A and we'll be able to address them. But I just want to invite Doreen to give her talk. Doreen is the GBV focal point of contact for Kenyatta National Hospital. She's also a trauma psychologist. Karibu sana GBV. She's very knowledgeable in the areas of GBV, and she'll be well placed to just answer any concerns that you may have about GBV. So Karibu sana Doreen, can give us your talk.
Thank you so much, Dr. Kamau, and indeed welcome and good afternoon to all of us who are joining this afternoon as we delve into this topic of HIV and GBV overlap. And I want to start by saying that this is very, very important for us to be able to give comprehensive care to especially our patients in our comprehensive care clinic centers, or any other patient or survivor that may come our way. We need to really get this understanding so that we can be able to ensure that we can be able to reach epidemic control. Because I must say that the links between HIV and violence can limit us from getting to that epidemic control if at all we are not going to address the issues around GBV. So I don't know, Dr. Kamau, if I can start sharing my screen. I see my screen was like removed. So
you can share it. You can share it.
Okay. Thank you. Just a minute and you'll be there. And kindly confirm if my screen is there, sharing. Thank you. And I want to start by saying that the mission of KNH is to optimize patient experience through innovative evidence-based specialized healthcare, to facilitate training and research, and participate in national health policy formulation. And what we are doing this afternoon is simply to facilitate our training. And the objectives that we have in this regard is to simply gain a basic understanding of gender-based violence and get to know who is affected, and understand trauma and adopt a trauma-informed mindset. Also be able to identify the links between HIV and violence, and at the same time get to know what exactly is this first-line support. I want to start by just refreshing our minds a bit by talking of what is this GBV, and we know that gender-based violence, any form of violence against an individual that is basically based on issues around biological sex, gender identity or expression, or what we can talk of perceived adherence to socially defined expectations, or of what it means to be a man or a woman, a boy and a girl. And I want to say that violence affects the different life stages of a person. That is when we talk of an infant, a child, a teenager, a young adult, an adult, and even elderly people, as we are going to see along. And GBV, when we talk of GBV, this includes sexual violence, whereby we talked of either attempted sexual assault or sexual assault, attempted rape or rape, attempted defilement or defilement when it comes to children, talking of intimate partner violence, and also anything around child sexual abuse, like what we talk of neglect, deprivation, or what we see the early or forced marriages, and also physical, emotional, psychological abuse that comprises of issues like threats. There is lots of coercion, arbitrary deprivation of liberty, and economic deprivation that we see along in economic violence, whereby one can be as a capability to be able to go and get a source of income, but they're limited in one way or the other. And I want to say that GBV is rooted in gender-related power differences, and most of the time it is characterized by the use and abuse of physical, emotional, financial power and control. What about HIV? We well know that this is the virus that causes AIDS, and we know that HIV attacks the immune system. And we know the immune system is what fights all the infections. And so what happens if one is infected by the HIV, one may be unable to fend off other illnesses. And also when we talk of AIDS, a deadly disease that interferes with the body's natural ability to fight infection. And let me say this, when now we bring the issue together of GBV and HIV, remember the immune system is attacked the same way when GBV now, the issues of violence, they also bring about lots of stresses that can now be able to bring about what we call the biology of stress that produces lots of stress hormones within the system that now we can see lots of the onset of NCDs, non-communicable diseases, even among our HIV patients. And that is why screening is as well very, very important. Let me say that healthcare is one of the entry points for survivors. And many individuals will have contact with the health services several times during their lives. And we all agree that many people come seeking services, and it can be from any entry point. Let's talk of, we've seen many come, maybe they want to access medical attention in regard to maybe they are coming with their eye issues, what we know like a black eye, or someone has issues to do with their dentals. And we find these people coming many, many times to the health facilities. But if the screening is not enhanced, we might miss out some of these opportunities, and we are going to see as we move on with the presentation. And I want to say that GBV is interrelated to and impact many dimensions of an individual's health. And I want to give an experience that I found at the Department of Mental Health. We find a case scenario of an individual who was sent to the department simply because they went through lots of assessment, what we call, there was no medical explanation of the conditions they were presenting with. There were many occurrences of physical symptoms, but they couldn't exactly tell, the doctors couldn't tell exactly what was the issue. And this person was experiencing what we call upper Nakule syndrome, what we call psychosomatic disorder. And we see most of these disorders lack a medical explanation. And only to get to the bottom of it, that this person and gone through a traumatic experience, and they were not able to talk about it. And so they could feel this trauma was expressed in the physical symptoms. And after addressing that, that person was better settled, even in they were able to move on with their life. So GBV is to, and it impacts many dimensions of an individual health. A person can present with another issue, but there is an underlying issue, or there could be an encounter with the gender-based violence. Survivors tend to, survivors tend to access health services more than non-survivors. What does this mean? Is we find that if one has an issue, they always want to rush to the health facility, or maybe they have been told the best place that you can find help is in a health, in an health center. And most of the time, if we are not so keen, we might miss out these people because they might present with an issue. Maybe it's someone is presenting with a wound, or maybe someone is presenting with a back pain, or presenting with maybe a fracture. And so if we are not so keen, we might miss out on such people. And also, many people know that in an healthcare setup, providers are trained and they can be trusted. Sorry, it seems that something as, sorry. So Dr. Kamau, are you presenting?
Yes, I'm presenting. Yours got lost, sorry.
All right, sorry for that. So, and also the providers, I was saying they are trained and trusted individuals to talk to. So a person will always think that I would want to go to a healthcare. Next, Dr. Next slide, please.
Sorry, it's not moving, but just give me a minute.
Just an illustration. Okay. This is simply an illustration of asking about GBV, how it is able to help clients so that they can be able to understand their health impacts. And remember a case scenario that I gave. And this is simply a survivor who talks of, I was dying without realizing it when the physician told me that my health problems were related to what was happening in my house. I must say that most of the time when these survivors go through violence, it becomes like a veil that is on their eyes. And we are going to look to see why does this appear to be so. So wow, the screen. Okay, sorry. Okay, so what is our responsibilities as the providers? I want to start by saying that we must have an understanding how GBV and HIV interact, and that will help us to prioritize the client safety. And I think that's what we are doing today. Also to know that it's our responsibility to create that safe environment, that when these people present to us, they know, remember what I talked about, the healthcare as an entry point, that they are expecting that it will be more safe for them. They are going to find a safe space for them. And also understanding how gender power differences impact access to resources and interactions with the health system. Reinforcing the value of your client through your words, body language, and actions, and also respecting dignity by involving the client in decision-making, so that we are not there to always tell them what to do, but we can be able to involve them. Providers are not responsible for one, solving violence for the survivors, determining the legal aspects of the violence or assault, determining whether a client is telling the truth about GBV, mediating relationship problems between a couple, forcing a survivor to leave an abusive relationship, knowing all the answers. We don't know everything, but we can always work together because this GBV-HIV issue is a multi-sectoral that needs multidisciplinary engagement to be able to see how to support. Who is affected by GBV? I earlier mentioned that violence affects all the different life stages, and we can see the children, the youth, the older persons, the widows, people with disabilities, low wage, informal sector workers, key POPs, and talk of female sex workers, people who inject drugs, men who have sex with men, transgender persons, prisoners, people in conflict and crisis areas, refugees, internally displaced persons, and indigenous, ethnic and religious minority communities. And I want to say that to make this mention, persons of different sexual orientation and gender identity, when you talk of social class, the religion, and so on, are never a reason for violence. So we cannot justify by saying these minority groups are supposed to undergo violence. I want to talk of the statistics by WHO that talks of women and girls who are at increased risk and disproportionately affected by GBV, but this doesn't mean that men are not affected by GBV. And the reason why I want to bring these statistics is to show us that there are many, many cases that are not yet supported, and we will yet see why people don't come out for this support. And so 1 in 3 women worldwide have experienced physical or sexual violence, and this has happened not from a stranger out there, but an intimate partner. And when we look at the percentage of females and males aged 18 to 24 years, and these are the people who reported sexual violence prior to age 18. And this was the survey that was done by CDC in 2017. And this was Violence Against Children survey. And we can see in Kenya, I'm interested in Kenya, we can see that the sexual violence that was reported by females was 32%. And when we look at the violence by males, it was 18%. So that tells us the children who were violated before the age of 18 years, the percentage that is being shown. That tells even the males also undergo sexual violence. What are the potential signs and symptoms of violence? Ongoing emotional health issues, such as stress, anxiety, and depression. So anytime, these are some of the red flags or the markers that can be able to draw some keen interest when we see an individual is having ongoing emotional health issues. Remember, I said that gender-based violence is a very stressful issue. And so if you get across someone who is undergoing stress, reporting of I'm feeling depressed, like maybe a patient, maybe in the HIV clinic here just comes, and every time you're finding out how they're doing, they talk of, I'm under such pressure, I'm feeling so stressed, I'm anxious, I cannot be able to engage in anything. That should be a red flag to tell you it is an opportunity for one to screen GBV. Harmful behaviors such as misuse of alcohol or drug. This is a maladaptive behavior that one may be want to have a way of coping with maybe the issues that they are going through, and maybe GBV could be one of them. Thoughts, plans, or acts of self-harm or attempted suicide, or maybe could be having the suicidal ideations. Injuries that are repeated or not well explained. And I want to give an example of a child who came to our accidental emergency. And this time, this child came unconscious. And so we, after examinations, and they realized that there were marks of a human bite on her body. But the story behind when she was brought was the girl was kicked by a donkey and she got brain injury, but only for physical assessment to show that there were marks of a human bite that were old enough. And also there were some bruises that were showing that they were not so fresh, but they were not for a long period of time. So that was now a red flag to show that more thorough investigations were to be done on this child. Repeated sexually transmitted infections. If every time you're treating STIs, it's also good to find out, could it be a potential sign? unwanted pregnancies, or what we call unplanned, unexplained chronic pain or conditions like pelvic pain or sexual problems, gastrointestinal problems, kidney or bladder infections, or headaches that they keep on coming and going. It could be a potential sign. And also repeated health consultations with no clear diagnosis. Remember the case scenario I gave of this particular person who could, go, all the medical examinations are done without anything lacking a medical explanation. GBV and HIV. I want to say that when one undergoes GBV, it can be a direct route of infection through forced sex. This can be a direct route of HIV infection through forced sex. And most of the time, this individual is limited. They don't have ability to negotiate safe sexual practices. And this also can interfere with the ability to disclose HIV status. If one is undergoing like intimate partner violence, it is not so easy to be able to disclose because you fear that you can get an additional violence. Also, it interferes with the ability to access healthcare services. And we are going to see how this impacts in terms of epidemic control, because most of the time we wonder, why are not people coming for their clinics? Why are not people, taking their medications as they should? Why are they not having protective measures in place? And there's also interfere with the ability to take medications. In a case whereby maybe one is infected, like in a despondency status, you'll find that the other person will not be able to take PrEP, because they fear that if this person realizes this is what they are doing, they are going to undergo violence, or also one is not able to take ARVs in case they seroconvert. And also there is increased vulnerability to violence. This becomes now when one discloses, if one may be present and test and they test HIV positive, they may fail to disclose. And the disclosure issues also come in, whereby we find these people who have not yet done their disclosure, and we wonder why. Because if when one is undergoing violence, it increases the vulnerability to violence as well. And also maybe by saying this is how my status are, they may trigger violence. And also increase stigma by partner and family, or even accused of infidelity by partner and family. And this increased stigma is also part of violence, psychological violence. And you see, this person may feel, I may not be able to talk about my status. There are a lot of reasons why a client may not disclose if they're undergoing intimate partner violence. These are not the only reasons, but I just decided to just put some of the reasons. And one, the client may be dependent on the perpetrator and fear losing support. Most of the time we wonder and ask people, why are you still in that relationship? What are you doing? Pack your things and go. And we forget that this client may be dependent. This is the only, the breadwinner that this person has. And so they might fear losing support, and their fears are valid. Another thing is the client may fear retaliation from the perpetrator, from friends, from family, or others. If they come and disclose, this is what is happening to me, the next thing, they might fear that the issue may get to another person, or the person runs away the friends. What will people say? What will my family say or do? And also so the person feels like, I just want to remain there. And there is a cycle in relation to that, the cycle of violence. And the cycle of violence that holds past an individual in denial, that they feel this might go, things might look up. I think it won't be this way forever. The person promises they're going to change, but it keeps on because they are still in denial. Because the person that they got joined to, or they've been relating with, didn't show some of these traits before. The client may not see the abuse as a problem. There are people who normalize that. We know there are also the cultural perspectives that a woman, for you to be shown love, you have to be beaten. So it has become, violence has been normalized. So there is nothing wrong with that. The client may not trust you. Very true. The client may feel that I don't feel you are the safe space for me, from the way maybe you engage with me from the start. And so I may not trust you to tell you this because I fear you might disclose to my partner. Their fears are valid. The client may fear losing their children, which is a great concern. That if I may disclose, this is what is happening, then I might lose my children. And the client may just not want to. And I want to say, whatever the reason, respect the client's decision to disclose or not disclose. I've had this narrative in the past. I don't know why you're there. I don't know what you're waiting for. I don't know. Why shouldn't you not just go? But these are some of the reasons as to why these clients may choose not to disclose on what they are experiencing. As I earlier mentioned, violence affects the entire HIV cascade. When it comes to the issues to do with prevention, when there is a risk behavior, and when one wants to ensure and encourage a protective behavior, when one is going through violence, then you can be sure that one can have inconsistent condom use, and there can be a higher likelihood of one being HIV positive. For example, if the partner has risk behavior and they don't want to employ protective behavior. There can be also lower PEP initiation and adherence. If one knows they have been exposed and they want to take PEP and they are undergoing any form of violence, you'll find that this person may choose not to start even PEP. And also when they start, they're not able to follow through. And also lower PrEP initiation and adherence. They may not be able to take up the PrEP and because they are experiencing violence. And I want to say that, as I earlier mentioned, violence is a barrier when it comes to achieving HIV epidemic control. And that is why we must address, we cannot leave out GBV issues. When it comes to testing, you find that one may not want to take up a test, HIV test. And remember what we talk about, the movement, they are limited in terms of their movement. There are people who undergo violence and they end up being locked even in their houses. They cannot be able to move. They don't have the freedom of movement. And so you find that they are not able even to know about their status. Non-disclosure of HIV status to partners. And I want to say, if they're not able to take up maybe a HIV test when they are presenting to the facility, they present when they are quite at advanced stages. And also there is lower likelihood to link to care following an HIV positive diagnosis. For now, we are so keen in test and treat, which has become a challenge. And we can agree to that you find an individual, they have tested HIV positive, but they say, let me go think about it and I will know when to start care. I will know when to enroll for care. But there will be a lower likelihood if this particular client is undergoing violence because they don't know. One, remember we say that they might not be able to disclose because of the ongoing violence, which disclosing the status can trigger another violence. So there is lower likelihood. And this now tells us why people don't want to be linked to that care. And when it comes to treatment, we see significantly less likely to initiate treatment. Say, yeah, they're still buying time. And they say when to. And if those people still start treatment, they are more likely to be lost to care. We've heard of situations whereby one hides medicine somewhere, in the house, and they don't want to disclose this is what is happening. And and they can be limited in one way or the other. If even the movements are restricted, they may end up even getting lost to care, or if they are going through psychological violence, verbal abuse, threats and all kind of things, they be more likely to be lost to care. And remember, this person is not only experiencing one form of stress, there is also this other form of stress, the HIV burden, and at the same time, also undergoing violence, and also the pill burden is also part of it. So, and when it comes to suppression, survivors are significantly less likely to be virally suppressed. So this should serve as a cue that when we get some of these patients coming, our clients rather, in the CCC, and we are wondering, why is it that they are not virally suppressed? It is of importance for us to be more concerned about what could be going through their lives. More likely to miss appointments and forget to take medications. So that should also be able to serve as a guide when it comes to when we are inquiring what could be the issue. Sorry, my screen is lost once again. Sorry for that. Don't know, been kicked out from this other gadget. I don't know, Dr. Kamau, if you can be able to project.
Let me share.
Okay. Sorry for that. These are some of the technical issues experienced when we are relating this way. And yes, now we are done with the cascade of the violence effect. Yes, and now we come to why should we care about trauma? It's very, very important because people who undergo GBV, they experience trauma. And also we find those people who undergo GBV, they can also, who went through GBV when they were children, they can re-experience GBV as well. So the reason why we should care about trauma is many current problems faced by the people we serve may be related to traumatic life experiences. Some could have undergone a childhood trauma when they were young. And we've been able to find such cases, even in the mental health department. You find someone has a diagnosis of maybe a major depressive disorder. And after doing your assessment, do your history, you find that this particular person underwent sexual gender-based violence when they were young. So it is very, very important to care about trauma. And people with histories of trauma may be sensitive to situations that remind them of the traumatic event. So anytime we ask, why are they not talking about it? Could be this person has a history and they feel that that area is so sensitive for them to relate it because it is reminding them of the other traumatic event they went through if they have never processed some of these emotions. And these reminders also may cause a person to view our services as a source of distress and not as a healing and calming environment. So if we are not so keen, or now we talk on issues around trauma, we become a source of distress as well. And we don't become a healing and welcoming environment. Remember what I said in some of the reasons why they don't want to talk about this? We could be the source. It could be that they don't trust us. And there is what we call transferences. Maybe a person who maybe made one to undergo a trauma looks like maybe me when a client presents to the room. So if they have never been able to deal with those issues, when they look at me and I look like the other person who caused trauma, then I will become a source of distress and they might not be able to trust me. So what does that mean? We need to create an environment, a safe space for them whereby they can be able to feel that they can be able to relate with, and talk about this issue with time. We might unintentionally cause harm by being insensitive to their needs. And that is what we call it traumatizing. We don't want to be source of, to be causing unintentional harm to these clients. And that is why some of these trainings and more trainings of these are important. Recognize the role of trauma is as well very, very important. We don't know, as I've said, what kinds of experiences our clients have had when they came in for services. So we need an approach to approach them in a sensitive manner. And we are going to look at maybe one of the way to be able to deal with this. And also we should recognize the role of trauma, pay attention to signs of trauma and ask the right questions in a sensitive, non-judgmental and respectful way. Remember what we said? We need to respect our clients at all time. Next. So there is a need of changing our mindset to be trauma-centered. This was what often we think, and we either ask about this or this is some of the thoughts that go through our minds. What is wrong with you? You know, why are you not listening? Why are you being so difficult? Most of the time, we have labeled clients as difficult. And we can verbalize this or just ask it within us as we serve them. And what goes through our mind is also, our eyes also becomes the window of what goes through our mind. So what is wrong with you is an open, it's a closed question. If you ask what is wrong with you, I'll say nothing. Why are you not listening? One can choose either to answer or just ignore. And when you say, why are you being so difficult, that now brings a very big wall between the two of you. The wall is created and you cannot be able to penetrate through that individual. Next, Dr. And so there is a need of changing our mindset. And so when we change our mindset, it shows some form of concern. What has happened to you? And that one calls for lots of patience so that we are able to allow that person to feel as comfortable as they should so that they can be able to explain. And we're going to look at what is this one way we can be able to use. Why are our services not meeting your needs? This is very, very important because this is going to give a feedback. And this, for me, I will talk of people who are of an open mind. And they are also, we are open for a feedback to be able to ensure that we are able to give the right services. What can we do, change to keep you safe and healthy? That shows the professionalism. And as KNH, the motto is we listen, we care. And this time we are not just listening for the sake of listening, is listening so that you can be able to have an information that is going to help you to see how to support this person. Next. And it's very, very important to build trust when we are communicating with survivors. And I'll say the confidentiality issue is of great importance. Our patient, every person wants to feel that what they share, what they talk about is held with confidentiality. And we can agree not only to our clients, even to us as individuals, when you share your issue, you expect that when you're sharing a sensitive issue, someone is going to hold it with the level of confidentiality it deserves. So it is of importance to let our clients always know of confidentiality and at what point you can be able to breach this confidentiality. And at the same time, you can also mention of shared confidentiality because remember, this support requires a multidisciplinary approach so that when you're able to share about this issue, you have already talked about the shared confidentiality. Reassure healing statements. For example, you might be feeling this way today, but that doesn't mean this is what is going to happen to you forever. So it is okay not to be okay, but one of the things I assure you is that you will be better with time. And as we continue to support you, we want to assure you that you're going to regain back, you're going to stand back to your feet. Open-ended questions, kindly let me know how I can be of your support today, or how can I be of help to you today? And also listen actively. And when we talk of listening actively, this means that you're there, our whole being, you know. This time of now, we are becoming or getting to the digital platform. It's so easy to, you know, talk to an individual and you're on the computer or on a machine and you're like, you know, putting down everything. Kindly give the attention to this person by giving eye contact, not staring, you know, because remember, this person is already traumatized. Don't stare, but give that eye contact that says, I am here, I'm attending to you. And also at the same time, you're able to reflect. I heard you say that this and this and that. Did you mean this and that when you said this and this and that? How did that make you feel? You know, you're able to reflect to the client's feeling and also communicate without words. Like you can be able to show your involvement by nodding, you know, doing the minimal prompts so that this person knows that I'm there. And the other thing is, don't judge. If this person says, this is what happened, don't start saying now, and how are you dressed? Why did you go there at that time? What, blah, 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 and all that. Don't judge. Listen to them with no manner of judgment, and also empathy, getting to the world of that client and having the ability to get out of it, trying to identify with what exactly has happened to them. Next. And this is simply what we were talking about, the interpersonal communication. Combination of verbal and nonverbal skills. You can be able to listen. Sometimes you don't need to say much, but you can be present. You are there. You are able to know, use gestures, or your body language is very, very important. Active and supportive listening. You're there, you're presently there. And also give a voice to the survivor and make the survivor feel heard. And when you talk of give a voice to the survivor, is letting that survivor know, maybe you can relate to an issue, you can be able to, that is going to give the survivor a voice to be able to see the reason to keep on and even to stand and reconcile with self, and also make the survivor feel heard. And remember, this you can do with lots of reflecting so that the survivor will feel we are moving together, and that brings an issue of effective communication. Next. When, how do we ask about violence when it comes to the HIV programs? I narrowed this to HIV program because we are talking about GBV and HIV overlap. Next. And most of the time, as we already mentioned of the health entry, we see many clients presenting for specific services. And when we do screening to these clients or clients who present for specific services, if they are experiencing violence or they have fears about violence, is what we call routine inquiry. And according to PELFA, they always want us to ask these clients who are maybe coming for PrEP. We are supposed, when we are doing IPV risk assessment for PrEP, it is always good to ask if they are undergoing violence. Why? Remember, we talked of some of the limitation of these taking up PrEP, the initiation of PrEP. It can be limited by violence, so it is of importance. And also, if one takes PrEP without, if they have not, they are undergoing violence, it can also become a trigger for the additional violence. So it is very, very important to ask about intimate partner violence for someone who wants to take a PrEP. eligibility screening for DREAMS and OVC. And also when it comes to index case testing, and in this day and time, we are having the PNS is very, very important, so that you're not going to call the other person, or you're not assisting this other person to disclose about their status, and it becomes a trigger for the violence. We have programs that have option, and those are the HIV care and treatment, ANC and PMTCT, and we are going to see what is that type of screening that is supposed to be done. Next. And what I want to say that there are minimum requirements for routine inquiry. If you have to do this routine inquiry for all those people who are seeking those specific services, then you must have providers who are trained on how to ask about violence and to provide first line support. We don't want to unveil a wound for the sake of it and not dress and take care of that wound. It's better left unopened than just open it up and don't do the necessary. So there must be providers that, you know, even if it's me who is screening about this and I get limited to some point, I can be able to refer this person, or I can be able to call in someone to be able to address this. But mostly I will encourage whereby the person who is to talk about this, who is going to screen about this, to be able to give that first line support. Because remember, these clients don't want to talk about this violence to every other person. Remember, this is a dignity issue. So they want to deal with one person that they can trust. And so the person who screens that should be able to support them. And there must be a protocol or standard operating procedures or now to go about that. Privacy and confidentiality, I cannot overemphasize on that, ensured, and system for referral should be in place. And if any of these elements are missing, the site does not have the ability to conduct routine inquiry, the screening. Next, Dr. I want to say universal screening is not allowed. And most confuse routine inquiry, the screening, with universal. We don't. It is not recommended at all by PEPFAR and WHO. We don't recommend universal screening. That is all people at health facilities. We don't. And remember, I talked of the programs that are, it's an option, and asking only clients you suspect are experiencing violence is called clinical inquiry. And this now happens mostly in the setup of maybe care and treatment, and also in the ANC PMTCT. So, but when it comes to the clinical inquiry, you don't need to have minimum requirements. If you are conducting clinical inquiry, the priority is to provide the client with first-line support and offer or refer them to any additional services they may need. For example, if a client presents in a CCC, and maybe as a clinician, you note there is maybe a scratch, there is a red eye, or maybe the way they are looking, you can be able to tell because you've been dealing with this client before, and you can tell there is something that is not right. Then you can be able to make that clinical inquiry. And after that, because also in a clinical, in a care and treatment center, you have other like adherence counselors and psychologists, then you can be able to link that person so that you can be able to be given the support that they need. Or maybe you realize that this person has not been adhering well to the treatment. You can, and maybe you realize there is something also presenting within their physical, in their physicality, then you can be able also to make that clinical inquiry. Next. What's wrong? Let's go back there. What's wrong with this situation? Do we find ourselves in such setups? Wow. All right. Let's move and we'll see why that I want that pictorial presentation to be in your mind. Responding with lives, we have what we call, it is what we call first line support. And the first line support is a practical, survivor-centered, empathetic counseling approach that is able to respond to clients' needs. And these needs could be emotional, physical, safety, and support while respecting privacy. Go back, Doc, to the previous slide. So you can imagine maybe that father there who is bringing those two children to health facility. Because we said also men can undergo violence. So it's not only women. So for example, if that man is undergoing violence, because that can tell many things, is the one bringing the children to care. Most of the time we know what we are used to is that we see it's women. So if that man could be undergoing violence and the clinician who is seeing that man is asking, has your wife ever forced you to do something sexually that you did not want to do? That's not a good environment for that man to respond if he was undergoing any form of violence. Next. So there must be an emphatic counseling approach so that one is respected and feels there is privacy as they are being asked these questions. Must be offered right after client discloses violence. This first line support is offered right after client discloses violence. So if a client presents to you and they have not disclosed about violence, then you cannot be able to use this approach. And first line support has helped people who have been through various upsetting or stressful events. And with the right training, anyone can be able to do this. Next. So this is the WHO who defines first line support using the acronym LIFES. LIFES is simply with these are 5 letters, and the first one is listen, L. And remember, we listen closely with empathy, no judgment, that you can allow the client to talk about the issues that they are going through with empathy, that you can be able to get into that client world and you can be able to listen without judgment. What they say, you don't judge. What they say, you don't dispute. Inquire. You're able to access and respond to clients' needs and concerns, which could be emotional, physical, social, and also showing some form of practicability. For example, if someone presents with, and you're trying to find out how they are, and they talk of, this is what is happening to me. I have a cat that is bleeding right away, even as I'm seated here. The practicability is to ensure that that injury is taken care of as you do this. It goes hand in hand. You're not just there sitting to inquire to the end, but whatever presents first, you're able to address it. That is why it is first line support. And also when you're doing the inquiry, you don't overwhelm the client with many questions. Remember, as they are coming to you, they are already overwhelmed. So don't overwhelm. And allow them to disclose and talk as far as they are comfortable to do that. That's why as you inquire, you can use a word like, do you feel comfortable to share with me what really happened to you? And by allowing that chance, they're able to disclose as much as they feel comfortable. Then validate, show the client you believe and understand them. What do I mean by you believe? All their concerns and their feelings, every time a client presents, they are valid. They are valid. And so validate. I can imagine all that you're going through. and I believe you, what you're telling me, what you went through. Because that person has entrusted themselves to you so they can be able to share what really happened. Enhance safety. Remember what we talked about, some of the things that the professionals don't do. You don't create safety for them. Go back, Dr. Takshari, but you can be able to discuss on how to protect them from further harm. For example, if that person says, I'll still go back to that house, and then you can be able to discuss how to ensure that that client is protected from further harm. For example, if that person is a woman and is always in the kitchen, where do you keep your knives? You know, where are the knives kept? You know, so that you ensure, do you have the key for the door that you can be able to, in case things are not as they should, you can be able to escape? Do you have a contact of someone that you can be able to reach out to? Do you have or know a number that is an emergency you can be able to call? What you're doing, you are enhancing safety for that person. Because remember, with the various issues, reasons why they cannot come out of that abusive relationship, there could be, as they are coming up with a way, or you're supporting them to be able to see how they can be able to get out of that abusive cycle. Then you need also to discuss, as they are there, what are some of the ways that can enhance their safety? Support through referrals. Help them to connect to the appropriate services. This could be social support. This could be issues like also connecting with the psychologists, mental health practitioners who can be able now to support them. Also, if it's a key pops, ensuring that they connect with the friendly services and also youth-friendly services to our youths. Next. Great. At this point, I want to say that documentation is very, very important. We usually say with no documentation, it shows that there is no work that has been done. And why is it so important to do documentation when it comes to the issues around GBV and HIV? This is very important because it is able to provide us the ongoing sensitive care, and so that you are able to remind yourself or alert another provider at a later visit. Remember, we are working as a team, and there is that shared confidentiality. So if that a client presents and don't find you and go to another provider, it will be so, it's doing some form of injustice if they have to keep on asking them, tell me, or screening violence issues over and over again. But when there is documentation, it ensures that you are able to provide that sensitive care so that what the other provider is able to see, and they will keep on going, they'll keep on from where you left. And also, it is important because IPV can affect care and treatment outcomes. So documentation can help tailor services. That if you know this person is undergoing through this, the issues around adherence counseling when one is not adhering well to medication and treatment, how can you be able to ensure that we are giving services that are really meeting the need? Documentation can help improve program service quality, yes. And also proper and complete documentation can help lower the risk of re-traumatization. Every time having to ask the same questions. And also I must say that documentation also advises the way forward by helping in identifying the gaps and also coming up with a solution for focused interventions. Next. I want to bring this presentation we are almost getting to the close with the summary. And I want to say that gender-based violence is a common issue globally. And many of the population we serve are at a higher risk of experiencing GBV. We remember very well with the COVID and now post-COVID, these issues were quite elevated because people were now able to relate more closely. There were lots of limitations in terms of movement. And we know sometimes people are able to vent out when they go out to the workplaces and engage in other businesses, and they tend to suppress. But I want to say it's a common issue globally. And intimate partner violence is one of the most common types of GBV. And experiencing violence can lead to trauma. And then standing out helps us to become more sensitive when we are dealing with our clients. And as I said earlier, because of the links between HIV and violence, we cannot reach epidemic control of HIV without addressing GBV. We cannot keep quiet. We cannot be silent anymore about the issues around GBV. And integrating consideration for GBV in our HIV services is an opportunity for a common goal. And I'm happy that we've integrated, especially at KNH, we've integrated services in various departments. This helps us now to be able to screen and be able to support these clients early enough before we get to that point of no return. Next. Witnessing, let me talk about this in regard to the providers, and witnessing the incredible resilience of survivors of violence can be fulfilling. Incredible resilience is whereby we are able to see the survivor go through the support, the trauma counseling, and they are able to get what I call self-reconciliation, and they're able to stand on their feet. It is quite fulfilling. What we usually term as that you're able to get that compassion fulfillment, that you've been able to support this person to this point, and they're able to bounce back. But nevertheless, frequently listening to trauma of GBV survivors and empathizing with and caring for them can also take a toll on providers' health and well-being. And this gives me the big question. Is it that health providers are undergoing what we call vicarious trauma? That's why they shy away from screening for violence. Are they experiencing what we call compassionate fatigue? This toll can be pronounced if the provider is also a survivor of violence and the resources are insufficient to meet their needs. And that is why we must be deliberate when it comes to supervision, the support. Like KNH, we have employee assistant program. I think it's a high time to make use of that office so that we can be able to get that support. And we are also going to see what are other ways the institutions can be able to help such people. It is important to be able to recognize when work is negatively impacting the health of providers. And it is important to be able to recognize when work is negatively impacting the health of providers and take the steps to address it. And this can be done by both individuals and also the employer. Next. I cannot leave out talking a little bit of 2 slides with self-care. And this is what I was talking about, burnout, physical and emotional exhaustion related to poor job satisfaction or helplessness, to resolve a problem, compassion fatigue, which builds over time. A provider can no longer emotionally respond or handle a client's need. And vicarious, or what we call secondary trauma, and when a provider experiences emotional distress as if they are personally experiencing the client's trauma firsthand. And also remember, we've said could be also this provider maybe undergone the trauma in the past or even violence, because we are not exceptional, even as we are prone to gender-based violence. Next. So when it comes to self-care, I've talked, it's a responsibility for both individuals and also institutional levels. And so there needs to be there needs to be a quality supervision for these providers, so that when they are able to meet, they can discuss the issues and administrative, client work, and even the individual issues, so that also they can be supported. Because who support the carer, who care for the carers. So it is very, very important. And also they debrief frequently with staff about their cases or work, maybe some of the cases they have encountered. And let me say one case of a GBV, because we are human beings, one case can make one feel like they have handled 10 cases. So sometimes we say, you might think an individual had just 2 clients in a day and you think that was a low workload. But one issue can make that person feels like can be overwhelmed. And so debrief frequently with staffs is very, very important about the cases. And also ensure that GBV providers are trained on lives and they're also comfortable using it. And of course, training that is able to provide opportunities for professional development. The greatest room that can never be filled is the room of improvement. So training helps us to keep on improving. Also organize team retreats and support formal and informal opportunities to socialize. It is not all about work with no play. Make someone lazy. So it is also important to ensure that there are retreats that are organized, that people can go and vent out their play, exhale, inhale, and all that. And also remember the employee wellness. And as I mentioned, for the KNH staffs, please take advantage of the EAP program so that you can be supported. Also, let's encourage formal and informal peer support. That when you feel you are quite overwhelmed after serving a client, meet with your peer and debrief. That one doesn't have to wait for the supervisions. That happens maybe once in a month. You can be able to support each other. And then work towards becoming a vicarious trauma-informed institution that you can always be able to support. You can always be able to ensure that your employees are not getting secondary trauma. Great, next. And for an individual, of course, you need to have self-care. And these types of self-care is emotional, can be physical, emotional, social, spiritual. What you feel is good for you and you can be able to engage in, please don't shy away from doing that. Remember, you're the only person who is engaging in this, and you don't have a replica of yourself. It's only you. And besides work, there are many, many other things. You are maybe a parent, you are a sister, a brother to someone, and you are needed in community, even beyond the work that you engage in. And so I want us, after now, exposing us to all these issues around gender-based violence, and could be maybe you've ever undergone, and maybe this presentation itself is a trigger. I want you to sit up and we engage in this calming exercise. So I cannot be able to see you, but I would want you to sit up on your seat wherever you are, and we engage on this calming exercise. And in case you feel a bit overwhelmed by this, because this presentation itself could be a trigger, then kindly reach out for support. So I want you to sit up. I hope you're there. I want you to breathe in through your nose for 4 seconds. So breathe in. I want you to hold your breath, then blow out through your mouth for 8 seconds. So that is what I want us to do. So I'll give us a minute to be able to engage in this, wherever you are, wherever you're seated, or if you're lying down on a couch or a carpet, and engage in this. So let's go. Great. And so you can do this on your own, and this can also help you in many other ways. Maybe when you're going in for an interview, you can be able to engage on this. When you're feeling anxious, you can be able to engage in this to calm yourself is one of the relaxation exercise. And so with that, I say thank you all. And for all that you do, remember to take care of yourself so that you can be able to take care of others. Thank you very much, and over to you, Dr. Kamau.
Thank you so much, Doreen, for that presentation. Like I had told you earlier, she's very knowledgeable in GBV matters. And I mean, I like the notes that she's ended on about self-care. And I'll just read the questions in the chat. I think most of them were about CPD points, but now I can see Muho Dongo says, as a medical social worker, I appreciate the knowledge and skills shared on GBV-HIV. And like really, Doreen reiterated and said, we can never achieve epidemic control. We want to come to a place where there are zero new HIV infections, zero HIV-related deaths, and zero HIV-related stigma. And we'll never get to that when, you know, we're not able to recognize GBV within you know, our workplaces or within our community, and actually get these people to get the help. Because really there is a power struggle and people are not able to admit they're going through it. And with GBV, like she mentioned, there is reduced access to care. So Anne Karanja asks, has anyone done research on this fact that intimate partner violence is the most common cause of GBV? Are we looking at upscaling preventive measures, for example, through the school curriculum and religious organizations? Doreen?
Thank you. I can see Rose Mukabane is on the call, and I would request her to answer that. She is the GBV focal point of Nairobi County. So Roslyn Mukabane.
Okay, in the chat, she said that, you know, Nairobi County has integrated SGBV services in key service delivery points. However, I noted that the rehab team, that is physio and occupational therapy, are rarely included in the training. So I think the county has been involved in a lot of trainings. So Doreen, like for the school curriculum, what do you think would be something that we could use, you know, to put into the curriculum for school-going children to be able to, you know, be aware of SGBV or GBV?
Yeah, I agree that the school curriculum, we have what we call, we have the focal points, like in the Langata sub-county, we work with teachers who are the focal points of contact within the school. And I'm sure that is still a discussion undergoing, that they can be able to better advise on how to go about it. We know many things have introduced in the curriculum, like sex education, but also they are working on how to ensure that also the issues around screening and also creating awareness within schools can be incorporated. But I think that is already happening, though in a small way. It might not necessarily be in the document, so to say, but it is happening, you know, when there are meetings and they are able to talk about those issues in the small way. Yeah, so it is happening. And the good thing is that we have a focal point of contacts, because it can only happen through the connection and interconnections within various counties. And that is why I said I really wanted Rose Mukabane to make a comment in regard to that, and the issues also around the IPV outcome.
I don't know whether you can answer, Rose Mukabana, but I know like a lot of it is just WHO data, you know, that 30% of the women worldwide have been subjected to either physical and or sexual intimate partner violence. And I mean, and majority of this was by someone who they knew. So out of the like 30% who've been subjected to GBV, whether physical or sexual, 27% were from, you know, people known to this people known to these people. So, and not just known to them, but an intimate partner. But Rose, we'll just follow up the question later on. We'll see whether she responds later on. So there's a comment, Jude. If one case can overwhelm a healthcare provider, do we have enough psychosocial support for our clients? Is the question Jude asks. Doreen, do you have an answer from experience and from, I mean, the work you're doing?
Yeah, from experience, I want to reiterate and answer that question that Judy is asking. Well, the psychosocial support is there. And I want to say, like Kenyatta National Referral, remember, these are some of the cases that are referred to the facility that are really, you can imagine the states of such a client. And for example, maybe I give an example of a child who was referred all the way from Kirinyaga. And I hope I'm not traumatizing someone, but this case came, and I've dealt with other cases, but this one quite overwhelmed me. That's why I mentioned about a case. And this girl was 7-year-old who was sexually violated, and at the same time, the eyes popped out. Went through theater to find if there is any sight remaining, and there wasn't. The reason why I said one case can overwhelm a provider is depending also with the magnitude. We are not superhumans. We are also human beings who got feelings and emotions that can be expressed as well. And I can tell you for sure that time I was coming from leave, and I was told there was a case that I needed to assess and see how to support. But when I saw that young girl, remember, I'm also a mother. That doesn't negate the fact that being a trauma therapist, you cannot imagine this could be your child. And when I went to see that girl, I was not able to do much. The girl was asleep. The mother was there beside numb. And I said, don't wake that child. I was not ready to see the sight of that child after getting the history. And so when I went into my room, I was numb for quite some time, trying to imagine what kind of action that girl went through. But to give the success story on the same is that girl is now integrated in the Thika School of Blight and doing amazingly well. And the family now supporting her very well. It was a rough road, I must say, but she's now back to her feet. So when I say that case can overwhelm a provider, it also depends with the magnitude. And we cannot negate the fact that we are human beings. Yeah, so, but the thing is, a good thing is always keep on ensuring that there is a supervision, call in for help. Remember what I said, as providers, we don't have all the answers. You can always call in someone you can refer the case to another person to deal with. And when you also feel that you're overwhelmed, also reach out for your support, even with your personal therapist, because that is also, that is important. So some of the cases with depending with the magnitude can make an individual just see one case. That's what I meant by saying one case. Doesn't mean that person is not supported or they are not able to do as much, but it depends with the magnitude. I hope it has been answered. Thank you.
I think you've answered it well. And I think one of the things that has really come out from your answer is that I think we all need to recognize GBV. And not necessarily just give it to the work of probably people who are, who are in the psychosocial department. And I think quality is very important in, what we are giving our patients. That's really important. So, I mean, I think the reason why we've also done this sensitization is that you all need to just recognize and really need to listen. Like she gave us the live training. Let's learn how to listen, and where you can't handle, refer and really talk about what you see. So, I mean, there are lots of people who are thanking us for the presentation and, thanking, saying it's very informative. Brenda would like to know what we are doing to curb cases of GBV in schools, even as we journey towards the triple threat. And what is the current policy on revealing HIV test results to a partner?
Before that, Doc, I can see Roslyn Mukabani is requesting to be unmuted. So she can be unmuted from your end, please.
I don't know whether Nelson, can we unmute? Let me see.
Her name is Mukabana.
Yes, yes.
Just a moment. Yes, Rosalind, go ahead. You're unmuted.
Oh, thank you very much, Doreen. That was a very wonderful presentation, and I acknowledge our support that we are working together with KNH on response and prevention of GBV. The question that was asked on whether there has been any study done on IPV, yes. Through partnership with LVCT, we were able to do a study on IPV within Nairobi County. And yes, the numbers that came up, it was very clear. Because we did the study in informal settlements, and actually what came out is what Doreen actually presented when we were beginning the presentation on low-income earners, a lot of vulnerability within the women who are not working, and also those who are undergoing different forms of vulnerability. So the study is available through LBCT, and that can be shared. On the issue of schools and what we are doing, yes, there is a lot we are doing through the school health program, and KNH is also part and parcel of that program as we support the schools. Thank you so much. I would want to leave it at that. Thank you.
I think maybe Rosie can just tell us specifically some things, because people are really curious about school, what exactly is being done.
Thank you. What we are doing within Nairobi is we have specific days where we go to the schools with the school health program and with the mental health coordinator and the GBV focal persons. We have sessions with them and get to understand what we know about SGBV. And this normally we do them on an afternoon. And after that, we actually ask them to be able to write down what form of violence they have experienced in one way or another. And this is in confidence. And then when we get those papers that give us, we now allocate different training days, different days to go and provide those psychosocial support and pick out. And unfortunately, like the last, before we closed schools, we did get a number of school children who are undergoing violations from teachers and also their parents, also part of what we are calling intimate partner violence in quotes. And we were able to support them through lives, and that's why we are working now with teachers to also take them through the basic line in terms of labs, so that they can also be able to identify signs of sexual abuse among students and do appropriate referrals to us. And also we are working through the DREAMS project and the OVC project and the partners that we have within our county, able to also have the ones who go to formal schools. We also make sure that we visit and we have safe spaces where they can also come and talk about what we're undergoing. Not forgetting that we also work with the boys in terms of to get to understand what types of violations they're also going through, and having sessions with also what we are calling the adolescent fathers and mothers. Thank you.
Thank you so much, Roslyn. I mean, it's really nice to hear all that is going on, and I think we've been able to address the question that we had about that. So I think somebody else was asking about the policy on disclosure. So we don't disclose HIV status. We have partner notification services that we do, so that if you encounter somebody who is HIV positive, you contact their partners and invite them for testing. But intimate partner violence is one of those things would actually stop us to do that, because we're actually putting someone's life at risk by doing that. So that would be the one thing that would not do the partner notification services for. I think we've addressed most of the questions. Doreen, can you see any question that we've not at least touched on? Because I see we are beyond time.
No.
Yes, I think we've addressed all the questions. Want to thank you so much. I think we had attendance of close to like over 900, and we are really grateful that you came and you joined on this. Do you have any parting shots, Doreen?
Mine is to say thank you for listening in, and let's take care of ourselves as we take care of others. Thank you and bye-bye.
Yeah, thank you so much, Doreen. I think mine is just, I hope that this has helped us to understand how important GBV is, even in HIV prevention, in HIV treatment. You can't do one without the other, as you've seen. And that's why we really wanted us to be aware of this. And also we've gotten an opportunity to realize that there are so many things that even is being done within the county towards GBV. So mine is to ask each and every one of us, as you take care of yourself and you make sure that you're well enough to take care of someone else, look for these patients and get help for them. So thank you, and over. We're all welcome to leave at leisure.